So today I want to talk about how we have been moving the needle on quality and post-acute respiratory care. It was in Tennessee, but now it's also in Chicago market as well. We've got a lot of things going on up there. We have a lot of other movements we're making over the next few years, but we're quite proud of the fact that as respiratory therapists, we've been able to enter into the Medicaid world, the Medicare world, and really make a difference and change the needle, raise the quality of care. So I'll get started with that. Reverse. Prior to 20, let me get back to that. 1957, I was born. Prior to 2013, we provided hands-on care of the complex respiratory population in skilled nursing facilities. We left that realm and went into the different market. As some say, we joined the other side and went on to the TennCare side of things and started talking to TennCare about how we could develop a pay-for-performance model in long-term ventilator care. And that model we did develop. In 2014, it rolled out officially and has been in place ever since here in the state of Tennessee, ever since then. So by doing that, these facilities that we work with are getting paid for the quality and also for the technology that they're using. So the more technology they use, the more their point scores, the more wings they have, the more decannulations, the better off their scores are, and the more they get paid. So we implemented that model. Then we moved into some other areas, into the home, and I'll get to all this in a minute. But we have initiated a high-touch outcomes management program. We do use the Nexus software, so that's been very helpful for us. And so without further ado, I'll get into more in depth there. Our programs consist of enhanced respiratory care, which is the nursing home ventilator market. The complex respiratory management is for home mechanically ventilated and tracheostomized patients and other patients that have complex respiratory needs. Our population outcomes management program is for the walking, talking COPD population. We've had some very good results with that. And all of these things have had one goal, and that is to improve outcomes and to save money. We've now entered into a remote patient monitoring program so that we're now capable of doing end-tidal CO2 and pulse oximetry in the home, which has been extremely good for our Katie Beckett kids that we have. And as of hopefully January, we'll also be providing that in the adult market as well with a home ERC model. So enhanced respiratory care, as I said, these are ventilator units that are set up in the wall of the skilled nursing facilities. What we do there is we make sure that the facilities are in compliance with standards of care. We improve the medical oversight. We've improved their staffing. We've improved the use of technology by way of this pay-for-performance model, as I mentioned. We've improved the training and competencies for these facilities, so they're taking a lot sicker patients than they used to. And of course, we focus on the quality outcomes, the weaning, and reduce complications, hospital readmissions, things of that nature. So again, what I just said, we improve quality, we improve safety. We have decreased the LTAC utilization. There's some patients who, instead of going to an LTAC, can go to a skilled nursing facility level of care and avoid the higher cost LTAC, but there are still patients that go to LTACs, as you know, and we do support that when it's necessary. And then we monitor the outcomes, the weaning, decannulations, and then we have this transitional program in home. So basically, we partner with skilled nursing with payers. We find skilled nursing facilities that are interested in participating in the program. We evaluate each patient before they leave the hospital to decide if they're going to go to an LTAC or to a SNF level of care, and a SNF is the skilled nursing facility. And once that decision is made, we collaborate with the payers, admit the patients, and then do whatever we can to make their lives better. And sometimes that is the magic for that is just good old-fashioned care, and caring for the patient makes all the difference in the world. On several occasions, we have built companies and transitioned them, and each time somebody comes to us and says, we're trying to find out what your magic pill is that you're doing to make all this difference, and the big pill is that we're just treating people like people, and we're taking good care of patients. And that's basically it. You can get a lot done with that. We have strict admission criteria. These were published in CHEST some, I don't know, years ago, I think back in the late 80s or early 90s. And so admission criteria to a skilled nursing facility, they have to meet these things. We don't want to take an unstable patient into one of these facilities because it is outside the hospital walls. So they have to have a FiO2 of less than 50%, for example, PEEP less than 10, stable airway, et cetera, et cetera. Our role is that our team manages the quality monitoring, as I said. We evaluate the patients before they make the move out of the hospital. We have been able to improve the outcomes in this setting, and our ventilator liberation rates and tracheostomy decannulation rates are over 50%, which is unheard of in a nursing home environment in most states. Here in Tennessee, that is not the case. It's expected that you'll hit at least 50%. Some of these facilities are doing much better than that, some a little less, but overall statewide we're at 50%. When new technologies come along, a lot of times the skilled nursing facility therapists don't get to see these things because that's a very small piece of the market. So if a new technology comes out, a new high flow, a new device of any kind, we are the ones that introduce that to not only to the therapist in many cases, but a lot of times that we introduce it to the payers because there's a wall between the facilities or the manufacturers and the payers that really is hard to penetrate. And by us being there in the middle, we can be the liaison to make that happen. So in the event of high flow, for example, in the home, we have gotten several of the payers to pay for that now, which has not happened in the past. So that's becoming a trend here in Tennessee and in other places as well. But in the nursing home segment, it used to be that the common thing people said was, well, we can't afford to have one of those. We've changed that situation where you can't afford not to have one of those because that's how you get paid in part anyway. So the more devices you have that are being used, then of course that adds to your points. And then we evaluate tracheostomy members outside of the skilled nursing facility ventilator units in regular nursing homes. So we may get a referral to go to Billy Bob's nursing home somewhere, and we'll find a tracheostomy patient, and they only have one in the building, for example, and they take this one and they don't know what to do with it. But we will work with them to try to get the patient decannulated, to get them moved to a safer environment and make that decannulation happen or something of that nature. But there are a lot of those trach members that just sit in nursing homes for years and years and years and nothing ever happens, and that's just wrong. We're trying to change that. Our wean rate statewide, 51%, as I said, statewide is not too bad. Same period last year it was 48, so it stays in that range, 48, 50%. We've hit 60% before. Our days to wean, as you can see, are about 30 days, which is, again, fairly remarkable for a nursing home environment, that we can get them in and get them out in 30 days, or get them off the vent anyway. Decannulation rate is above 50%. Unplanned hospitalizations are something we really struggle with and work hard to eliminate, but a lot of these patients do go back to the hospital for various reasons, and sometimes it's family driven. They want their loved one transferred if they blink twice. You know, it's it's hard to control that. So, but we do try to. Unexpected deaths, you see we monitor that. Infection rates, technology, we look at the point system there again, how many pieces of equipment they have. And not only they have it, but that they use it. That's the big thing. And then we set these facilities into a tier score, where they're scored as a 1, 2, or 3 tier facility, and their payment model or payment rate adjusts to intervene and raise that needle on quality. This was a 37-year-old female that had a substance abuse problem history. She came into our facility, or into the facility, February of 24, and by May of 24, she was liberated from invasive ventilation and decannulated. Again, though, we pride ourselves on those kind of cases because we know they would be there forever if we weren't there. Because again, their wean rate was 18%. So unless she dropped her trach on the floor and it came out, then she would have been there forever. So it all went so well that the payers came to us and said, let's take this into the home. Let's see what we can do there. So we have a complex respiratory management program. We see all of the ventilator-dependent and tracheostomized Medicaid members in the state of Tennessee that are in the home or in a nursing home. We see the nursing home patients about once a week. These patients at home we see whenever we need to. And that might be once a week, it might be once a month, it might be once every 6 months. But when they're in the home, there's this possibility that they could improve and they could still be weaned, and so we watch for those occasions to come up. We find there's a huge gap with this lack of education and understanding of home ventilators, of home tracheostomies, things like that. We try to fill that gap, provide extra training for the families. There has been in the past a lack of clinical oversight. Once a patient went home, it was kind of like a dump, and once they're there, and that's where they'll be forever. And we don't see that as a good way to do things. We like to look for improvements or ways we can improve their lives. There's a lack of monitoring and ongoing support, and there was truly a lack of advocacy on the part of the patients and their families. They would be so frustrated because they would try to get a piece of equipment, or they would try to get a hold of their doc, or they would try to get appointments made, and it just wasn't working, and there was nobody out there advocating for them. So our respiratory therapist, which now stands at about 40 or so, I don't even know, you'll have to tell me, but around that area, 40 across the state and in Chicago. But they are now the advocates for these patients, as well as being the respiratory therapist that helps take care of them and educate the families. So that's a big part of what we do, and that's an area that we all need to be involved in, is advocacy for a patient. Zach mentioned that earlier. If we don't advocate it for them, I don't know who is going to. But all of those things that were negative resulted in commoditized care and inappropriate equipment utilization and unnecessary cost to the managed care organizations, which translates to unnecessary costs for all of us as taxpayers. So we've tried to make that a little different and improve that. The patient then has a poor quality experience, and so we have found that 90% of the patients that are referred to us need some type of intervention, and that intervention may be to get a piece of equipment, like I said, to call the doc. It may be to find food for them. Lots of things like that go on behind the scenes. So the benefits of that program, reduced ER visits, of course, reduced hospitalizations, reduced device abuse. We have been able to get patients very compliant, and we'll talk about that in a minute. But a lot of times patients have pieces of equipment that they get referred or get prescribed for them, and then that piece of equipment goes in the closet. So we want to make sure that if they do need it, they are using it, but we don't want anything in the closet that we're paying for as taxpayers. Improve compliance, improve quality, and improve member satisfaction, which we think is a big thing. If the member, or and I say member interchangeably with patients, because in our world, we refer to them as members because they're members of the managed care organization. So it provides a unique opportunity to advocate on behalf of the patient with the DME suppliers. Likewise, we work with the DME suppliers. If they're not getting paid for something they're supplying, we work with them and advocate for them to the insurance carrier to make sure they get paid. So our job is really cool because whatever's going wrong in any direction, we can try to correct it. So our census breakdown, we have non-invasive ventilators, trachs, invasive vents, and then our compliance is, as you can see, there's about 75%, where the national compliance is about 57%. So we've been able to get these patients compliant, or if they don't need the equipment and they have it, to remove it. Our outcomes, as you can see, with a census that's going to approach 600 here in 2024, we can see the reductions in ER and hospital occurrences is down 72%, and that's still current in 2024. So we're still at about 72%. So that's a huge reduction. And it's one of those things, again, as was mentioned earlier, we've got great results. The problem is getting those results in the hands of the payers and the people across the country that make the decisions to put these programs in place. It's very difficult to get to that level. We're very fortunate that we now have 2 states under our belt, and that gives us a lot more credibility. And so I have to say it was a lot of fun for the hillbillies to go to Chicago and show them how to do it, you know. It happens. Our Katie Beckett program is for the pediatric cases that have special needs, that have special equipment needs, high technology needs, and we've been able to work with that population since 2021, and we've been able to keep the number of ER visits at a minimum while the population is actually growing. So we're quite proud of that. That's something that the TennCare folks report to the legislature every year, and they take our data and they report that to the legislature to keep the program going. And it was a program that came about many, many years ago, and Tennessee was slow to adopt it, but we finally did. I think we were one of the last states to adopt it, but it was created back during the Reagan administration. So you can tell how long that was. Some of y'all weren't born, I guess. And then from hospital admissions, we've had the same outcomes. We've been able to reduce that tremendously, even with an increasing population. And the families have a great amount of comfort knowing that if they have a need or if they have a problem or if they have a question, they can call us and we will get an answer to them. Our therapists are very good at that. And as a reminder, and I don't think I mentioned this up front, but we provide no equipment to these folks at all. Ours is all clinical services. So if we say a patient needs whatever, then the insurance company will approve of whatever, because we don't have a financial gain by putting that equipment out there. So that made a huge, huge difference in what we did. The Population Outcomes Management Program, as I said, that's a walking, talking COPD population. It's had tremendous results in all of these programs. We started with the worst of the worst patients, and that was the ventilator in a nursing home situation. And then we have worked our way down finally to where we're on the walking, talking COPD population. We currently have quite a few patients, and I'll get to that number here in a minute, but I'll get ahead of myself. But what we're looking to do here is again, decrease ER visits, decrease hospital admissions, avoid any DME costs that are unnecessary, which is good for all of us, and we have any kind of diagnosis. So we have become what we had hoped to become, and that's all things respiratory when it comes to nursing homes, outside the hospital, wherever we fill that gap. We use the CAT assessment test on every patient that we onboard onto our program. And that is a nationally tested and verified test. And we've had a 79% improvement in the CAT scores after 1 year in our program, in our outpatient program. So you can attribute it to kind of like a pulmonary rehab program in the home. We do a lot of visits virtually, and we found that, and we did that not by choice, but during COVID, before COVID, we saw everybody every month. And then COVID came, and we went virtual with telephonic visits, and we didn't see any big change in our outcomes. So we were able to stay with that, and that's not how we function now. Some patients are seen, and some are visited by telephonics. We have a huge factor is that 24 hours a day, 7 days a week, if a patient gets anxious or has a problem, they can get a hold of somebody, and they can get a hold of a respiratory therapist to talk through it, and that gives them a sense of security, and that has made a huge, huge difference in the outcomes. We are currently still working on this study, but we have taken the patients that have the worst anxiety and depression scores, and we have assigned somebody to them that's not a respiratory therapist, but is somebody that calls them and becomes their friend. And we call it the Care Bear program right now, for lack of a better word. But their job is to call them and say, how's your dog, how's your cat, did you get your hair done this week, those kind of things. If they have a breathing problem, they will tell that person, and it gets escalated. But the sheer fact that we're providing somebody to call and be their friend, we have such great comments like, and it's pitiful, but they say, I don't have anybody. I don't have any family. I don't have anybody that checks on me. You're the only one that calls me every week and says, how's your dog or how's your cat, that kind of thing. And we think that we're going to see a huge effect there when it comes to readmissions and ER visits. We're tracking all that. We're also segregating that into how many of these folks were in the program for 6 months and it worked, and how many were in there just a month and just are starting to call them made a big difference. And we think that we'll see a decrease right out the gate. Our census is about 1,000 to 2,000 at any given point, because patients come in, patients roll out. So we always have a fresh batch of patients coming in. We have seen a 62% reduction in hospitalizations, and we're very, very proud of that. Of course, that is extreme when it comes to managed care, because that's how the managed care companies make their profits, is by doing a better job, theoretically. Our other things that we found when we first developed the program, we thought all we got to do is be respiratory therapists, go out there and see them, do our respiratory stuff. Well, the first thing we found out was if these folks don't have food in the refrigerator or don't have power in their house, they don't care what we got to say. So we had to take our program and reroute it a little bit and say, let's take care of these daily needs first. Let's get them some food. Let's make sure they got transportation to their doctor's appointments. Let's make sure they got their lights on. Those kind of things. And you can see it's a ton of patients that have to have those interventions. And we see it every single day. The last program here I'll talk about is the Quality Enhancement Initiative. That was an odd one where a payer came to us and said, y'all did really good with all these other things. Now, what would you think about us giving you 30 of the worst nursing homes in the state of Tennessee, and your job is to improve their quality? And we said, why not? We can do that. We said, what kind of quality do you want to see improved? They said, anything. And so we set about to start this QEI program and we're paid by the payers to do this, to go into the nursing home. And we started looking at what were the things that the patients were complaining about the most, or what made them sad about being in a nursing home. And a lot of times it was things like, they don't put any ice in my water. My food's not warm when it gets to my room. A lot of really high-tech stuff we told these nursing homes. Why don't you put some ice in their water, and they were like, oh, okay. And they did, and it improved their patient satisfaction scores. So that in turn made the insurers happy. And so that's a program we're doing now. We're in our second year. We hope to have a third year, but the biggest problem we run into with this program is even though we're offering free services to the facilities, they don't want it. They have to opt in and they have to want this program. Otherwise, we don't exist. So it's really odd, and it's sad because there's a lot of quality nursing homes out there, or nursing homes you would think were quality, that had a great name or a big corporate name on them, that really just turned the help away, free help. They don't want it. They say, we don't have time for it, or we don't need it. When we know clearly they do, because they wouldn't be in our program if it wasn't the case. But here are our data from that program. 80% of the facilities had better satisfaction surveys. Again, ice and water makes a huge difference. Who would have thunk it? 55% of the facilities had a decrease in readmissions. 69% of the facilities had a decrease in infections. So with very simple things done by, again, respiratory therapists, we were able to improve the outcomes and improve the quality of care in these terrible nursing homes that were out there. Remote patient monitoring. I mentioned that we have the ability now to do end-tidal CO2 and pulse oximetry in the home. We've been using that on the pediatric population, and what we're doing there is more trending than anything else, so that we can see if they're having a common problem or a common desaturation at night. It could be something to do with who the nurses are on staff. It could be any kind of thing. But we look for trends in those monitored situations. And then when we find a trend, we try to go for the root cause of what's going on, what made it happen. So who benefits from that? So anybody with a... Did I just go quiet? No? Oh, sorry. Maybe I went deaf. Anybody with a chronic diagnosis that's high risk for rehospitalization could get this remote patient monitoring. Anybody that's clinically complex, anybody that may be actively weaning. We used to say we would never wean a patient in the home. But we found that with this equipment in place, we can make very minor adjustments if the patient tolerates them, and then we can monitor to make sure they're doing okay, and we can actually begin the weaning process in the home. That's a huge difference in where we used to be mentally, because we would have never done that without the proper monitoring. It wouldn't be safe. But now we can do it. So those analytics drive the practice. We identify trends, as I said. We are able to impact outcomes and address things that are going on quickly. And that, again, produces tremendous cost savings, and that's how we get paid. So the concept of respiratory therapists getting paid would be great. It would be great if we could bill for our services, all that, but we can't. So what we've done is we've found a way to make ourselves so necessary and improve outcomes and reduce costs that it makes sense for them to pay us to do the things we do. So we kind of backed into the whole payment model, which is what we've kind of always done or had to do, because our programs are what they are. So wherever a patient is in the state of Tennessee, whether it's in the hospital, nursing facility, or home, our job and what we do quite well as respiratory therapists, and I congratulate all of us for that, is that we do move the needle forward in post-acute care. So our next stops, we have the payer industry is a lot like other industries in healthcare. You will see people who were employees of a particular managed care organization here one day, and the next day they're with another organization that's in Pennsylvania or wherever. And they are experienced with our program, so the first thing they do is they call us and say, we want you to come here too. So as of today, we are online to go into Pennsylvania Medicaid in January. We had a visit from the folks from Arizona. They said whatever TennCare does in Tennessee, we're going to do in Arizona. So we're online to get there probably the second quarter of next year. And we've been approached by the state of North Carolina that has some real big problems there. And we'll hopefully be there sometime next year. So in spite of anything else in the whole world that's going on, we are seeing some growth because we're doing a great job, and that's what's important. And that will wrap it up. Anybody have a question I can answer? I'll be happy to. No questions? If not, thank y'all very much. Appreciate it.